to the Office, POL, Part 1. What is a POL? This is based on a white paper developed by the Laboratory Informatics Institute. In this section of the paper and the presentation, we talk about types of POLs and workflow, history and market trends, why do POLs exist, advantages and disadvantages of running a POL, how POL integrates with the entire practice, and POL or reference lab. What is a POL? POLs are laboratories that are owned, operated, and managed by physicians. In some states, POLs are managed only by individual physicians, not by physician groups. POLs are not laboratories that are owned, operated, and managed by hospitals, managed care organizations, or other corporate entities. Types of POLs are broken down into primary care, and those are doctors that are trained to provide primary care to patients, such as family practice or internal medicine doctors. Specialists are doctors trained to provide specialized care to patients, such as oncologists and hematologists. For more information about types of POLs, please go visit the white paper link using the link at the end of the slideshow or found in the YouTube description. The workflow in a POL is that the doctor orders the lab test, specimen is collected from patient, specimen is sent over to in-office laboratory, tests are performed on the specimen as ordered, results and analysis are given to the physician, and physician discusses results and options with the patient. History and trends are broken down into early diagnostic testing and diagnostic testing in the 20th century. Early diagnostic testing can be traced all the way back to Hippocrates in ancient Greece. He instituted a diagnostic criterion including listening to patient lungs, observing skin color, and examining urine. In 50 AD, blood in urine is linked to renal failure. This is the first time that kidney failure can be linked to blood in urine. Renal failure is kidney failure. In 180 AD, Galen, another early physician, links a normal fluid intake to normal urine output amounts. And he then describes diabetes as diarrhea of urine. 900 AD, Isaac Judaeus establishes a protocol for using urine in patient diagnosis. In 1300 AD, examination of urine under a microscope becomes nearly universal in Europe. In the 17th century, there are many techniques that are innovated, including literature related to body structures and the formation of scientific societies. In the 17th century, there's the first attempt to use pulse and temperature as indicators of illness, intravenous drug injections, identification of sweet-tasting urine in patients with diabetes. This would be where the name diabetes mellitus comes from for type 1 diabetes. In 18th century, there are also many innovations in diagnostic testing. In the 18th century, William Hewson develops methods for measuring coagulants in blood. Coagulants are clotting factors. This sets the stage for modern diagnostic laboratory practices. Methodology for the use of blood pressure and temperature as diagnostic factors is refined. James Curry, who was an early British physician in the 18th century, treats his typhoid patients by putting them in a cold bath as a direct result of this methodology for the use of blood pressure and temperature as diagnostic indicators being refined. Typhoid, of course, was a fever. Sir John Floyer's pulse measuring technique also comes about in the 18th century. Tichy's urine analysis technique. Dobson proves that sweetness in blood and urine for patients with diabetes is caused by sugar. Holmes develops a yeast test for sugar in the urine. In the 19th century, this is known as the era of public health. Independent laboratories begin to develop. Many American physicians go to Europe for training in laboratory techniques. American opposition to laboratory practice wanes as older physicians retire from faculty positions. Pasteurization, aseptic methodologies resulting in fewer deaths after surgery, Greater emphasis on hygiene practices, X-ray, microscopy, and about 1850 the first hospital laboratories are established. Prior to this, testing is done in the physician office or at the patient bedside. In the 20th century, stratification begins. That is, you start to see public health laboratories, forensic laboratories, clinical laboratories. They kind of start to group themselves by focus. In 1928, Alexander Fleming accidentally discovers penicillin. Domjak discovers sulfonamides do not harm humans and possess antibacterial attributes. This combination allows Fleming to usher in the antibiotic age, and combined with this Domjak's work, allows for new treatments of infections, because not only do you have the antibiotics, but you have the sulfonamides. Organizations are founded to certify laboratory personnel, including the American Society for Clinical Pathology, which was founded in 1922. Organizations combined with the new treatments coming out of the laboratories earned professionals respect and legitimacy by the end of the 1950s. In 1965, Medicare is seen as free money in the healthcare industry. In order to counter that, in 1967, the Clinical Laboratory Improvement Act, or CLIA, took effect as an attempt to regulate laboratory practice across state lines. In 1988, CLIA is amended to include nearly all laboratories operating in the U.S. In 1989, an estimated 98,400 POLs operated in the U.S. You will see variations, depending on what you read from the time period, between 20,000 and 200,000, and this variation is due to a lack of standard definition and to self-reporting of status by physicians. And you noticed at the beginning of the presentation the mentioning about in some states it means this, in some states that. Some of these issues related to standard definitions persist until today. However, back in 1989, 25% of all laboratory testing was conducted in POLs. In 1989, $20 billion was spent annually on laboratory testing, and POLs received $5 billion. In 1989, Medicare was paying over $400 million to POLs, and 16 states had laws related to POLs. This goes back to point number 1 on this slide about some issues related to standardization. In 1989, 16 states had laws. In 1995 onward, we find that there's a clearer understanding of regulations and acceptance of regulations, and that results in the CLIA waived tests growing from 8 to 40 in number. If you don't understand CLIA waived testing, don't worry. I will mention it a few times in this slideshow, but we will be covering it in later presentations, and you can read more about it in the white paper. In December of 2013, the number of POLs was estimated to be 120,399, or 49% of all laboratories. In 2013, 60% of POLs were running CLIA waived testing, and 24% hold certifications for provider-performed microscopy testing. PPM would be a form of moderate complexity testing, which is an issue that will be discussed later in presentations. Growth of POLs is expected to increase. Aging population of baby boomers is driving this because they have money to finance laboratory tests, and they also have an increased awareness of healthcare topics. Also, this is being affected by the softening stance of payers related to testing. Medicare, for example, has made some adjustments in testing that allow for greater usage of laboratory tests. And of course, there is the expansion of the CLIA waived testing list. And again, that will be discussed in later presentations. Why do POLs exist? Historically speaking, it's a subset of point-of-care testing, which is testing done at the patient's location. Clinical medicine became more complicated, and physicians needed to perform these tests. The industry was looking for a cheaper way to provide laboratory services, an additional revenue stream for the physician in some cases, and of course the underlying goal of everything is to provide quality diagnoses, treatment, and care for patients. So this additional revenue stream may be the case for some clinicians. Maybe they are looking for a cheaper way to provide services in the industry. Any of these bullet points could be applied, and of course it's not an exhausted list. The advantages and disadvantages of running a POL, before I get into those, it is important to note that in the early days, lack of regulation could have been considered a disadvantage, and these lists are not exhaustive. So advantages include quicker access to laboratory testing for the clinician, resulting in an expanded pool of treatment options for patients. Greater efficiency of the clinical workflow. Cheaper testing, which is subject to individual test pricing. This might not always be the case, but it may be. Patient comfort and happiness, including time saved by only having to go to one location or schedule one appointment. Disadvantages include physicians' offices being the only point of access. Some physicians may be reluctant to release results to a third party, for example, a hospital. This may be eliminated per the February 2014 changes to HIPAA that require a laboratory to give results directly to patients when requested. That will be discussed in the presentation on regulatory issues, but you can go ahead and view them in the white paper if you so desire. Physicians may not see the value in having a laboratory as part of their practice. Patients may feel uncomfortable about the physician office being a central repository of information. Cost of compliance with local, federal, and state regulations may be a disadvantage depending upon the regulatory environment of the individual practice. And again, this is not an exhaustive list of either advantages or disadvantages. How the POL integrates with the entire practice. It stores patient laboratory data in a form that improves information exchange between the laboratory and the broader patient record. It also avoids the disconnect between reference lab and physician office, allowing for tighter integration. The reference lab is not part of the physician's office, and therefore there are aspects that are very disconnected. Having it in your practice can avoid this disconnect. POLs can also assist the financial department by supplying data to track cost and revenue trends. And POLs can also use laboratory data to assist with population trends leading to appropriate interventions such as community education programs. This would be especially true if there's a rural physician and the rural physician doesn't have a hospital that's close by to rely upon and is kind of the central space for public health programs. The decision to have a POL or a reference lab is one that requires some consideration. Again, this is not an exhausted list of factors to consider. However, many POL tests are CLIA waived and simple to perform. In a rural environment, the POL may be the only option, and whatever the reasoning is that is used in the decision, it should be based on a balance of appropriate measures that serve the needs of both the practitioner and the patient. And that is really what's essentially important here. If it's valuable and meets the needs of the practitioner but doesn't meet the needs of the patient, it's not going to be very useful. And the reverse is true. If it's great for patients but not for the practitioner, it's just not going to work. So there really needs to be a thought process and a fact-finding process that's very deliberative that can weigh those needs. For further information, you can click on either of these links if you want to go to our website or if you want to go directly to the white paper and see the references for these slides, and also read about some of the other sections that I haven't covered yet. You may do so. I will also put these links up in the description. Thank you for your time.